Good evening. My name is LaPortia, and I will be your conference operator today. Please allow me to welcome everyone to the miraDry webinar titled Don't Sweat, Utilizing Microwave Energy as a Platform to Treat Excessive Sweat. At this time, all phone lines will be muted to avoid disruption from any background noise. Time has been allocated after the presentation for a Q&A session with our speaker. You may also submit your questions in writing throughout the presentation by typing them in the chat box in the lower right corner of your screen. We will try to answer all questions submitted during the Q&A time. Finally, if you experience any technical difficulties during the webinar today, press *0 and an operator will assist you promptly. I would now like to turn the conference over to Dr. Michael Kaminer, Assistant Clinical Professor of Dermatology, Section of Dermatologic Surgery and Oncology, Yale Medical School, Adjunct Assistant Professor of Medicine, Dermatology at Dartmouth Medical School, and Adjunct Assistant Professor of Dermatology at Brown Medical School. Dr. Kaminer is also the Managing Partner of Skincare Physicians. Dr. Kaminer, you may now begin your presentation.
Thank you, LaPortia. I really appreciate it. And I want to take a minute to welcome everybody and thank you all for taking some time out of what I know are busy schedules, because I can only assume yours is busy like mine. So thank you for taking the time. I will try and reward the time that you've allocated tonight by presenting information that hopefully you will find interesting, honest, and hopefully intriguing in ways that will at least stimulate some thought and maybe even stimulate some discussion at the end. So with that said, obviously it's important for disclosures. The second part of this is important. This webinar is obviously sponsored by Miramar. For my disclosure is I'm chairman of the Scientific Advisory Board of Miramar Labs, and I've done some clinical research for them and continue to serve as advisor to the company. I hope, and I hope by the end of this you'll all agree, that rather than this being a conflict, this is an asset. And you'll see that the information that we present is not only crystal clear with all disclosures, but is presented in a way that you feel is scientifically valid. And as we move through, I'll try and keep to that as much as I possibly can. So with that said, here's what we're going to try and talk about tonight. There's definitely going to be time at the end for questions and answers if you have them, or I'll answer as best I can, that is. Microwave and what it is what we're going to talk about first. Then sort of progressing to microwaves in medicine, and from there the logical step is in how we would use microwaves in actually hyperhidrosis. Then what the miraDry and Miramar team has done to create the device that we now currently use that's FDA approved, and then the safety of the miraDry device. And then this best practices at the end is going to be specifics of my clinical experience as it relates to what Miramar calls the best practices program. And you'll see more about what that means towards the end. So what I think is important to do, and when we first started with microwave, and I was helping out with Miramar a few years ago, it was really important to understand what microwave was. And the first way to understand it is to figure out where it lives in the electromagnetic spectrum. So if you take this area up here on the top where lasers are, you can see that lasers can live anywhere from some of the ones that are in the ultraviolet range, and obviously we all know about UV light, less than 400 nanometers. Then from 400 up to about 900 is the visible spectrum. And so you're getting up into here. And then to the right on this scale is the infrared. So we have we have lasers that we use in the visible wavelength, which is somewhere in this middle area. Then to the right on this scale, which is the infrared, we also use lasers, like some of the fractional lasers that we use for resurfacing. And then to the far right on this scale is radio frequency, so monopolar, bipolar radio frequency, even tripolar that some companies call it. And essentially, these are radio frequency technologies that we're currently using for skin tightening. So between radio frequency, which is all the way out here, infrared, which is into here, you have microwaves, which is right in the middle. So it's right along this electromagnetic spectrum that we know so well in dermatology and plastic surgery and other specialties. And microwave simply fits along the continuum. And the miraDry device operates at 5.8 gigahertz, and the engineers and the scientists at Miramar can explain more precisely about why specifically there. But suffice it to say, it's in the microwave spectrum, which is just a continuation on the electromagnetic spectrum that we all know. So what is microwave specifically? Well, microwaves are very short waves of electromagnetic energy that travel at the speed of light. And they're used to do two things. They can transmit information or power. And we all know what some of the common uses for microwaves. So there are over-the-air communication, things such as cell phones, wireless routers, cordless routers, or cortisones, I'm sorry. Radar, which is radar detectors that can detect range and speed, the same radar detector that we use to maybe alert us. If there's a policeman in front of us, it's the same radar that they're using to see how fast you're going as you approach them. And then for heating as well. And we obviously all use microwave ovens. But then medical devices is another application for this heating component. And that's what I want to get into next. But what's important is, in addition to microwaves living along the electromagnetic spectrum that is so familiar to us, the end effect of how microwave works when it relates to what we're trying to do in skin is simply relating to heat. And that is the same as some of the other things that we do. And let's talk a little bit more about microwave heating, and then we'll compare it to other things. Well, microwave heat tissue, or substances, including tissue, to a process that's called dielectric heating. And essentially what this is electric dipole molecules rotate in an attempt to align themselves with the alternating electromagnetic field. And this rapid movement of trying to align these dipoles causes frictional heat. And then that heat is what we use for our end effect. Now, not all molecules in the field that we're going to treat are created equal. For example, water has what's called a high dipole moment, which has a very high absorption for microwave energy, whereas fat has a low dipole moment, so a low absorption. So things that have a higher water content are more likely or more readily absorb the microwave energy. And so essentially what we're trying to do is then use this microwave energy in its most elemental form to be absorbed by high water content tissue, and then that gets translated into heat. So how is this different from other things that we use, energy modalities that we use in medicine? So essentially, the laser world that we live in is dictated by chromophores. So chromophores will attract wavelengths of light, and there's certain wavelengths of light that attract the laser energy will lead to localized heat. Now, water can be a chromophore, but the challenge when you use laser energy to try to get the sweat gland is that the depth of the sweat gland is so deep that there's this high water content dermis that intervenes between the source of the laser energy at the epidermis and the sweat glands below. So water can simply get in the way of the laser energy and sort of deflect and defer the heat so it doesn't reach its target. RF is different. The primary mechanism of action for radio frequency is based on resistive heating. And so basically the patient is required to close the electric circuit from the source to the return. And this, as the electric current flows through the body, it creates power that converts to heat based on what's called Ohm's law, or ways of looking at resistance. So areas of highest current density will create the most heat. The problem is that current will flow through the path of least resistance. So it's difficult to control the heat delivery in a homogeneous way and in a specific zone in a structure such as human tissue. It can be done to some extent with bipolar and monopolar RF, but it's not as precise and it's not as controlled, which makes RF a difficult platform for delivering heat to the area where the sweat glands are. And we'll get to some anatomy in a minute. So now you've got these sort of reasons to think about microwave for what we're going to do for sweat glands, and microwaves in medicine are not new. Microwaves have been used since the 70s and 80s, so there's 3-4 decades of experience with microwaves in medicine. And you can see a list here of a variety of different companies and treatments: BPH, keratoconus, AFib, and others. So what we thought we'd do is focus on BPH and give you an example of how the urologics device works, and then hopefully there will be a parallel from the urologics device to what we're doing here. So urologics is essentially a way to treat benign prostatic hypertrophy. So you have this enlarged prostate, and what you do is you insert the device through the urethra and into the bladder, and then you inflate the balloon, which is number 1 on the cartoon on the right. Well, within the device that has been inserted through the urethra is a microwave antenna, and microwave antennas are really the engine that make all run. So you have this microwave antenna that's running through the middle of this tube, and around the microwave antenna, the blue on the screen that's next door, adjacent to the number 2, that's coolant. So you have this microwave antenna running right down the center of the urethra. You have coolant that surrounds the microwave antenna, so it basically protects the urethra from the microwave energy. And as the antenna emits its radio waves, for lack of a better way of putting it, the microwave energy ends up in the prostate gland, which creates heat and tissue shrinkage, but the wall of the urethra is protected by the coolant that surrounds the microwave antenna. You're going to see something almost identical as we move to the phases of how the miraMOS system is designed. So let's talk then. So now we understand a little bit about microwave, where it's been. We'll get a little bit to where we're going, but we need to understand what we're trying to treat. And the world of hyperhidrosis is interesting, at least to me, because when we were dermatology residents and other specialties, it was sort of, hyperhidrosis, understand it, end of discussion, because really all they could do is either go have surgery or end up in a pharmacy trying to find something that works. And now that we have a treatment for it, we actually need to understand it. So true hyperhidrosis is characterized by abnormal perspiration beyond what is required to regulate the body in a normal setting. And underarm sweating specifically is produced through two types of sweat glands. The eccrine gland, which is a clear, odorless fluid. Another way to think about it is eccrine is the wetness of sweat. And the other gland that's in the same general anatomic region is the apocrine gland, which is a thicker fluid, and that has the distinctive odor of sweat. So eccrine is the wetness, apocrine is the odor. And for people who have axillary hyperhidrosis, these glands are A, overactive, B, frequently activated instead of at rest, as would be in the normal case. And then C, they produce significantly more sweat than is required to cool the body on the normal homeostatic mechanism. So we sort of want to think about, how do we define hyperhidrosis? How do we define excessive sweat? Well, the best way to do this is through what's called the Hyperhidrosis Disease Severity Scale. The shorthand for that is HDSS, and it's a term that you're going to hear a lot. So the HDSS scale has been validated, which means that it's been independently validated to be a true measure of sweating so that it can be used as a research tool. And it's a powerful way to, A, assess efficacy in research settings, but B, to really get a sense of how your patients are sweating. And that's ultimately what we're trying to do, is figure out where our patients are, what bothers them, what their sweating is doing to them, and then we can decide how best to help them. And so there are 4 different levels. 1 is my sweating is never noticeable, never interferes. 2, my sweating is pretty much tolerable but sometimes interferes. And HDSS of 3 is my sweating is barely tolerable and frequently interferes with my daily activities. And 4 is my sweating is intolerable and always interferes with daily activities. True hyperhidrosis that can be diagnosed as medical grade, for lack of a better way of putting that, hyperhidrosis is an HDSS of 3 or 4. And it's a simple scale. You simply ask your questions. We actually hand them a piece of paper that has these 4 questions on them and ask them to put a little check box. So hyperhidrosis, true hyperhidrosis is HDSS 3 or 4. People who are sweat bothered are an HDSS 2, borderline of 3. And so it's the 2s, 3s, and 4s that we're going to be talking about trying to help, which is a big segment of the population. And here you go. Here's a little bit about what that population is. So this is a study that was done back in 2009, 661 consumers is how it was put. And based on that study, when people were asked how they sweat, and we'll get to some of the details in a minute, 21% of the United States adult population described themselves as suffering from excessive underarm sweat. And in this case, it was on a 10-point scale. But I'll sort of show you how that correlates with HDSS in a minute. Now, 4% of the population in the U.S. has already been diagnosed with true axillary hyperhidrosis by a physician. And you can look at the pie chart at the bottom for sort of a scale. So 4% of the U.S. has got true diagnosed hyperhidrosis. But an additional 17% consider them sweat-bothered enough to where it's a problem. Now, of that 17%, 7% have already been to a cosmetic surgeon, whether it's plastic, derm. Basically, they're an aesthetic consumer. And 10% of the sweat-bothered have really never sought any cosmetic treatment. So 17% probably are HDSS 3 or 4s if you use that scale, and I'll show you that in a second again. And 4% already have been diagnosed. So 1 out of every 5 people in the United States would describe themselves as so bothered by their sweating that it interferes with their daily activities. Here's another way of looking at it. So here's the same 21%. On the left-hand side, so 79% describe themselves as not sweat-bothered, and they suffer on average from 2.5 sweating events per week. Sorry, hopefully that was clear enough. I'll take that off for a second. So that's the 2.5 sweat events per week. But both the 17% and the 4% sweat about 10 times per week. They have about 10 sweat-bothered events per week. So the 17% and the 4% sort of the same way. If you look And another way of what this means is of the people, the 79% who really describe themselves as normal sweaters, even for them, 40% of them say that they're sweat bothered in social situations. But if you look at the 17% and the 4%, they are sweat bothered in a way that's almost identical. 89% in social situations are so sweat bothered it's problematic. And so it's just another way of validating that that number is accurate, that 21% of the population, 4% already diagnosed, 17% yet to be diagnosed by a physician, sweat so badly that it interferes in a way that they might seek treatment. And so what would be the objectives of treatment if those people were to walk in the office? Now you have 1 out of every 5 patients that you're already seeing, in theory, is saying to themselves, boy, I'd love to do something. The treatment objectives would be to subject the sweat glands to a therapeutic heat dose, which is enough to cause thermal necrosis, but at the same time, minimize heating of surrounding structures to minimize side effects while maximizing efficacy. And some of the challenges that the miraDry and the miramar team had was the extremely dense network of sweat glands in the axilla. There's 50,000 of them. So you can see how you really need to have a really effective and complement treatment to get true sweat reduction, whereas spotty treatment would still leave quite a number of glands intact, uninterrupted. They're located very deep, and there's a variability in subcutaneous fat and the distance from the surface of the skin. These glands can be anywhere from 2 to 5 millimeters from the surface. Not only can it be 2 to 5 millimeters from patient to patient, but within each patient, that surface can change because of the reedy ridges and the undulating nature of the dermal fat interface. And so there's inter-patient and intra-patient variability in skin thickness and sweat gland location. That's the big challenge. That's where you're trying to find a way to deliver heat. And so, now we're going to start to talk about, well, why microwave for treating sweat? And I'm going to show you some specifics. So the microwave, as we've already talked about, can easily penetrate to the depths where sweat glands reside. And since it's absorbed by high water content tissue, voila, that's what sweat glands are. They're high water content tissue. So now you have sweat glands in fat. Fat has that low dipole moment, not readily absorbing microwave. Sweat has that high dipole moment, does absorb the microwave, so it's a natural selective target. And what's really interesting, sort of the secret sauce, as I like to say, of what the miramar scientists did, is they designed the microwave antenna so that it preferentially targets the skin fat interface. And I can't overstate enough, A, how complicated that was, but B, how intelligent it was, because microwave antennas can be designed in a multitude of ways. And by designing the antenna to target the dermal fat interface, it eliminated the question of how deep that sweat gland was or that dermal fat interface was from patient to patient. The device does it automatically every time from patient to patient. And in some areas where the dermal fat interface is deeper and more superficial in the same patient, the device corrects for that because of the antenna design. So now you have this antenna that delivers the microwave energy. It penetrates most materials with very little limitation. So what that allows us to do is also introduce surface cooling, which I'll show in a second. And therefore, you can have an external source from outside, non-invasive device that can send microwave energy that will be like a heat-seeking missile to the exact area where the sweat glands reside, and we can protect the surface by cooling, all because of the technology that's in that box. I'm going to get in a second into the anatomy, but I want to show you just a little bit sort of as a teaser for efficacy. And so miramar has done a really nice job, at least in my opinion, of dividing up the research among multiple centers so that the data is not sort of all from one site, for example, such as ours. But it's also been done in multiple countries. So there's 120-patient U.S.-based FDA study, and there's also a lot of Canadian data. And what it shows down here at 12 months is that in the vicinity of 90% of patients will have both efficacy and subject self-rated satisfaction, and about 90% of patients feel like their sweating has been improved with longevity and stability after 12 months. Now, I know that this data also goes out to 18 to 24 months. We're just not showing it here. But what you have here at 15 months is a subset of the patients who were followed longer, and there are 14 of them. But of those 14, 100% of them, I think that's optimistic, but 100% of them say that their sweating has been reduced to be an HDSS 1 or 2, which means that they're sweating, quote-unquote, like normal people, but every one of them satisfied with the quality of their results. Now, the reality is we never get 100% satisfaction, so this is just because of the sample size. But it at least tells you that there's somewhere between 90 and 100% of our patients are going to be satisfied with the results based on the current device. And we think we've optimized that. And we now have data that shows that that number is more than 95% with some of the new treatment techniques that we'll talk about in a minute. All right. So let's get a little bit back to anatomy, start to understand what things are, and then we'll start to talk about some of the specifics. So here are the two different kinds of sweat glands. The eccrine glands are in blue. So the eccrine is that wetness of sweat gland. And the apocrine gland, which empties out of the hair follicle, is the odor of sweat. But they both live in that same zone, sort of in this high subcutaneous fat right at the interface with the dermis. And this sort of dermal fat interface is the key. And just below it, where the sweat glands live, that's the target. Now remember, the sweat glands have a high dipole moment, so they absorb microwave energy preferentially a little bit better than the fat compartment that they live in. And you can see how that helps out to some extent in just a minute. All right. So this is sort of the cartoonish version of what the microwave does. And I think just spending a minute or two here will help everybody understand what we're trying to do. So on the surface here, where that red line is, that's the miraDry device placed on the skin. These semicircular lines are essentially a cartoon of microwave energy being deployed. And the microwave energy is deployed in a way that it then reflects off of here, this dermal fat interface. So the microwave energy enters, goes deep into the dermis. Now on cartoon number 2, the microwave energy has come down to the dermal fat interface. It reflects off the fat and starts to go backward. And this reflection zone right here, hopefully these red marks are showing up, where the microwave sort of reverses on itself, deep in the dermis at the dermal sub-Q fat interface. That's where the concentration of heating is because of the absorption of the microwave energy. And so now you have heat in the deep dermis. You've got these sweat glands that are going to preferentially absorb the heat as well. And now in cartoon number 3 at the bottom, now you introduce cooling. And what the cooling is going to do is the cooling is in the surface system. It's going to push the fat down deep. Not the fat. It's going to push the heating down deep into the fat. All right, so I'll say it again. Cooling that comes from the surface device pushes the heat that was in this very deep dermis down here, and it's going to push that heat deep into the below the dermis into the superficial fat. And so now you have two different ways that the apocrine and eccrine glands are going to be targeted. One, they preferentially absorb microwave energy over other objects in the area or other structures in the area. And 2, you've got this cooling pushing the heat into the area where the sweat glands live. So it's sort of a double whammy. And the sweat glands at that point receive so much heat that they're preferentially injured. And here's going to show you what the injury looks like. So here's histology. On the left panel, that's baseline. You can see circles circling the sweat glands. At 11 days post-treatment in the middle, there's same circles trying to show where there's a little bit of necrosis of the apocrine and eccrine gland. So you don't see any tubular structures anymore. They have been destroyed preferentially, because you can see there's no other inflammation in this central histology. But those glands have been preferentially destroyed by the microwave energy. And 6 months post-treatment, you can see all of that fibrosis and cell necrosis has resolved in that superficial fat, deep dermal zone, sort of through here. All of that fibrosis is gone, and now you have just normal-looking fat, but you don't have any gland. And the key is that once a sweat gland has been destroyed, as humans, we cannot grow new sweat glands after birth. And so as adults, we kill the sweat glands, we don't have the capacity to grow new ones, and once they're all gone, we can't sweat anymore. And that's basically what this does. So here's what the device is now. This is very different. When we did the first treatment in our office several years ago, this device, the nice miraDry device that looks like a nice console, was 4 or 5 different electronic things with multiple engineers sort of sequencing things. Now it's this nice little console. It fits nice in the corner of an office, and with all the devices we have, having a little device that's tucked away in the corner is great. There are 5 different energy levels that are programmed into the machine. They are important as we start to talk about efficacy, which I'll get to in a minute. There's a chiller and a pump to deliver the cooling that drives the heat down into the subcutaneous fat. There's a vacuum pump to acquire the skin, which I'll talk about again in a second, and then the software that drives it. The microwave, the handpiece has actually 4 antennas that were built into it And what those 4 antennas do, they give a 10 by 30 millimeter zone of therapy. So it's a confluent zone. There are no skip areas. And then if the device is deployed according to the way that we'll talk about in a second, you basically get a confluent delivery of microwave energy, which is why efficacy is so high. And then again, the cooling is to protect the dermis. This structure here on the bottom right is what Miramar's calling the BioTip. It's a single-use disposable tip. But because of the suction, which is from this white area around the outside, it literally pulls the skin away from the underlying structures that we want to avoid, and it also stabilizes the treatment zone so that you get a nice confluent delivery of microwave energy to the skin that's been acquired and pulled away from the deeper vessels. And so how does this work? Essentially, the miraDry procedure is 2 treatment sessions for most patients. Those treatment sessions are 3 months apart. The first treatment takes about 60 to 90 minutes of office time. It's usually a little bit longer than the second treatment. So in our office, we allocate 90 minutes for the first treatment. And that's because there's some education of the patient, a little discussion of the side effects, which are usually swelling, and in some patients, some numbness and tingling of the forearm and fingers, which is temporary and goes away. So it takes a little bit of time to explain that to patients. The second treatment goes much faster. Again, it's 3 months after the first. And that one in our office usually takes 60 minutes. And each treatment itself has 3 primary steps. You can see in this photograph of the patient's axilla, there's what's called a temporary skin marking or tattoo. There are multiple different size marking grids. And so essentially what the operator does is he custom size it for the patient's axilla. And that way everybody gets a custom treatment based on their size. Once that skin marking has been placed, then the operator will put anesthesia in. There's also individual markings in the axilla to show exactly where to do that with the anesthesia. And then the third part is the treatment. It takes about 15 minutes per side to treat. It's easy to do. In our office, our nurses do the treatment. They actually really like it. They get to bond with the patient. So and the treatment itself, once the anesthesia has been placed, in our experience, has been painless. So we talked a bit earlier about the energy settings, and this is important just because it sort of ties into efficacy. There are 5 settings, 1 through 5. The default is 1. We started treating all of our patients with the first set of treatment at a setting of 1, and even with some of our second treatments kept it at 1. And it turns out that each setting is a slightly longer microwave antenna on time, and not surprisingly, the longer the microwave antenna is on, the more heat it delivers, the more efficacy. Now, the corollary is the more heat you deliver can cause more swelling and a little bit more numbness and tingling, and so you have to find that right balance. When you treat at 1, efficacy with 1 treatment is about 60 to 70%, and with 2 treatments can jump to about 80 up to 90%. So the key is to treat at slightly higher settings than 1. And as we've had our device longer now we're treating people starting at a setting of 2 for most patients, except for our very, very thinnest patients. And when they come back for their second treatment, we're trying to treat them again at 2, or if possible, even at 3, if their swelling wasn't so bad. And I think if we do that with 2 treatments, we're going to be well in the 90% efficacy. And for those people who are still sweating a little bit after 2 treatments, well, it's a real simple solution. You just treat them a 3rd time. And you just pick the treatment setting that works for them. And cost is a factor, and we can talk about that a little bit later. But we know that with 2 or 3 treatments, we can get almost everybody well into the high 90% to stop sweating. Now, here's what I think is just an interesting slide. This is a starch iodine test of a patient who is treated. The left-hand panel is 3 months after treatment. The right-hand panel is 2 years after treatment. The green square indicates the treatment zone. So this was in the very, very early days where we used the test devices. So instead of treating the entire axilla, we treated this green square area. And you can see at 3 months after treatment, there's no sweating. At 2 years after treatment, there's no sweating. There's been some question about whether there's darkening on the 2-year panel of the starch iodine as compared to the 3-month panel means that they were sweating more. It doesn't. It just means that more iodine was placed on the 2-year one than on the 3-month one. But the sweating afterwards in those areas that were not treated is identical, but the treatment zone stopped sweating in the absence of dark in the starch iodine test. There's proof that that area is not sweating. Now, interesting, in this patient, there's also no hair in the area that was treated, and that's food for thought and another area for potential further investigation because it's not surprising the hair follicles live pretty much right where those spark plants live. So Just as a summary for where we are and why Miramar as a company feels that they've sort of got a nice concept for treating underarm sweat, and in practice it works as well. It's non-invasive. It preferentially targets the region of the skin where the sweat glands reside and is relatively specific to sweat glands. And it causes direct thermolysis of sweat glands, but instead of photothermolysis, as you would get with a laser, it's microwave thermolysis, but the concept is not changed. We have lasting results. We think what we're seeing is permanent. We have patients now out to 18 months and 2 years who are no longer sweating, and since you can't grow new sweat glands, it's unlikely that those patients are going to start sweating when we're finally 18 months or 2 months out. We have, I think, really good data. There's a lot out there. There's some things that have been presented from the podium. There are publications if anybody wants to get a little bit more about that. And then obviously the FDA has weighed in, and it is FDA approved specifically for the treatment of primary axillary hyperhidrosis. So let me talk just for a couple of minutes about my experience in our practice, and then hopefully we'll have some time for questions at the end. So what we did as skincare physicians is we treated in what was called the Best Practices Program from June to October of 2011. And the objectives at that point were to confirm the treatment protocol, meaning the 2 treatments 3 months apart, provide some feedback on the commercial use and the procedure itself. And so there was an initial group of 19 patients that were treated with the miraDry system. You can see the demographics of who they were. And these people were basically tracked. 53% of those 19 patients had more than 5 sweat outbreaks a week, and 84% were HDSS 3 or 4s, which means that 16% were HDSS 2s, because a 1 wouldn't want to be treated. So we treated 2s, 3s, and 4, and in clinical practice, that's who we're going to be treating. And 74% of those 19 had 2 treatments, and they were followed with an online survey. So the procedure itself, the treated patients, it took about 90 minutes, and again, that first treatment session took longer. The research staff in my practice did these treatments. They are not nurses, but they are experienced research practitioners. Now that we've had this device FDA approved in recent practice, the treatment is performed by RNs and LPNs, which in Massachusetts we can do. The patients tolerated the procedure extremely well. They did get a lot of swelling, and you've got to tell them about it. And many of them did get a little bit of numbness and tingling. It goes away within a couple of weeks, as long as they know that they're going to get a lot of swelling and the numbness and tingling. We didn't get any phone calls from them about patients being worried. But before we realized we needed to explain this to them, when we were way back in the research part, patients called all the time. So once you set the expectations, the patients are fine with it. And the second procedure is part of the treatment protocol. And I tell patients that 100% of patients need 2 treatments to get optimal results. We have yet to need to treat 3, interestingly. So these are our patients. There are 9 patients. Remember, we talked about the HDSS score, and I think, again, this is going to become part of the lexicon of what we talked about with axillary hyperhidrosis. And you can see the blue bars are pre-treatment, and the green are post-treatment. So if you look at the HDSS 4s, pre-treatment, there were, I believe, 6 that were in HDSS 4, and after treatment, there was a 1. And 78% of treatment, 78% of patients after treatment dropped to an HDSS 1 or 2. Now, I think we could have been better here, and part of the reason why we have so many green patients that are green squares that are 3s and 4s is because I'm conservative by nature. When we did these treatments, we treated everybody at very low settings, and it's because I wanted patients to get results without complications. Now, it turns out that we could have pushed a little bit more energy into, instead of treating at a level 1 or even 2, we could have driven a little bit more microwave energy. And it turns out that when you put more microwave energy, as we already talked about, you get better results. And so what I would do now with these HDSS 3 or 4s that are persistent is I would just treat them a third time in a higher setting. But what we could have done to prevent this after 2 treatments is just driven a little bit more energy. And so I think now that we understand the way miraDry and microwave works better, we're starting to do, as we do with many other devices, really, really fine-tune it so we can really drive people to the left on this scale to HDSS 1 or 2. And it's energy dependent and the number of treatments dependent. And I think that's an important take-home point, at least for me. And the result, there have been no long-term side effects in our practice. Again, a lot of people get swelling. Some patients get a little bit of numbness and tingling, but it always has gone away. It always does go away. At 3 months, the patient satisfaction, 67% were very satisfied or somewhat satisfied. And you can imagine that the 3 out of the 9 were the ones that we maybe could have treated at a higher energy or who would need a third treatment. And again, it's the same 6 out of 9. Definitely probably would recommend it to a friend. And if we can sort of pick up those other 3 out of the 9 by treating them again, being a little better with driving the energy in with the first treatment, those results would improve quite a bit. So in summary, I think miraDry has been successfully added certainly to our practice and to many other practices as a treatment solution for patients with excessive sweating. But these oftentimes are new patients who had not previously been seen in our practice. I just saw a woman on Monday from England. She had been following this for several years, sort of had a sense that miraDry was on the horizon, wanted to wait because she was sweat bothered, and she came in specifically to have this done. And she was in her mid to late 30s. I think she's going to become a patient of the practice for a long time because she sort of understands what we're trying to do, and she was a good candidate. She was actually an HCSS 2 to 3, somewhere in there. All of our new patients that are coming in who have a sweating issue, remember, 1 of 5 people who we already see are sweat bothered in our practice. So we're going to see new people who haven't come in, and we're going to see old people, not old, but we see people in our practice, in fact, most of them are on the younger side, who are already sweating. Many of them are getting treatment with miraDry. Not all, because in Massachusetts, Botox is still covered by many of the insurers, and it's attractive because they don't have to pay a copay for those treatments. That is changing. Many of the insurers in Massachusetts are starting to cut back, and we're seeing a shift to miraDry from our existing insurance-covered Botox patients. But that's going to take some time. And a lot of the patients, we've done some internal marketing in our practice. We have a policy, don't advertise, so we haven't put ads in the papers. But we have a newsletter we send out. We have informational sheets in our practice. We have a poster that we put up so that people have a sense that we're doing this. And patients are asking about it, and there's been a little bit of a groundswell. And it's interesting. Even in the past 3 to 4 weeks, we've had a significant uptick in the number of people that we're treating. We're now up to treating at least a couple of people per week. So with that said, I've spoken long enough, and I'd love to hear your thoughts, but I want to thank you all once again for taking the time to join me and the rest of the Miramar team that are behind the scenes. They put a lot of work into trying to get this information to you, so I thank you for taking the time to listen to me, and I'm happy to answer any questions, and hopefully you have found this to be interesting, maybe even a little bit entertaining, but honest and informative. And once again, thank you, and I'm happy to answer questions.
At this time, I would like to remind everyone that all phone lines will continue to be muted. You may submit a question via the chat box in the lower right-hand corner of your screen, and the moderator will read your question aloud. Please go ahead.
Well, I don't hear anybody on the line, so maybe what I will do.
I got
you. There?
Yep, I got it, Doctor.
Oh, there we go.
Sorry about that. So we have our first question is, how deep does the energy go, and are there any system safeguards?
Yeah, it's a really, really good question. So we talked a little bit earlier, just briefly, about depth. We know that the sweat glands live anywhere from 2 to 5 millimeters below the skin surface. And so the simple answer to the question, and I don't intend to be flip, is the microwave energy goes as deep as the sweat glands are. But the science behind that is that if you remember the anatomy of where the sweat glands live, they live in that dermal fat interface. Well, the microwave energy will reflect off of that dermal fat interface back up towards the surface of the skin. And so that's the depth that it goes. The microwave energy reflects back off the fat, so it doesn't go more than maybe a millimeter or 2 into the fat, and then it reflects back up towards the surface of the skin. There are additional safeguards. So in addition to the way the microwave antenna was designed to get that microwave energy to reflect off the fat, there's the suction component, and the suction pulls the skin away to do 2 things: to seat it properly so that when the microwave antenna is deployed, it's making proper contact, but it also pulls the skin about 7 millimeters away from the deeper structures. So you're sort of pulling things away from where sort of the other things are that are very deep, like blood vessels and nerves, and the microwave energy is reflecting at about that 2 to 5 millimeter depth. So that's where the safety margin comes.
Great. Our next question, is there any compensatory sweating associated with this procedure?
Yeah, it's also a really good question. We don't see it when we do Botox injections, and interestingly, the same thing happens with miraDry. There's really zero compensatory hyperhidrosis. It happens a lot with sympathectomy, which is why so many patients have moved away from it. And I don't have a patient who's had that procedure done in years. But we have not seen any of it. So it obviously speaks to the specificity, should I say that one fast, specificity of the miraDry device.
Okay, we've got a few people asking about the cost of the treatment.
Well, I'm always reluctant to give specific pricing just because I don't want anybody to accuse any of us of price fixing. So what I can do, though, is give you some ranges. Essentially what we know is that most patients, in fact, everybody is supposed to have 2 treatments and some will want a third. There are some physicians and practices that are packaging the pricing, and that package price for 2 treatments ranges anywhere from about $2,500 up to $3,500, and I've heard it's even high as $4,000 for the 2 treatments. Other practices are choosing to do it to pay as you go. And so the average price for a treatment is around $1,500. Some are as high as $2,000. There are some practices I know of that are charging a slightly higher fee for the first procedure and then dropping it to the second procedure because it's a little bit shorter. So, for example, it's $1,500 for the first one. They might charge $1,200 for the second. So if it's $2,000 for the first, they might charge $1,500 for the second. And then this concept of, anybody can buy me a third. Everybody that I've spoken to is basically just trying to cover costs. Now, that's not inexpensive, but the number I've heard is around $1,000 for that third treatment, and I assume there are people who are going a little bit lower than that. But that's about the ballpark of what people are charging.
Okay, great. Here's one asking about what side effects are you consistently seeing?
Swelling, and swelling. Pretty much everybody swells. There are patients who get really significant swelling, so baseball-sized swelling. It's not that common, but people do get it. But everybody gets some. So we just tell people that they got to expect it. If they're a tennis player, don't plan anything that's competitive for a couple of weeks to make sure the swelling goes down, or if they're doing anything with their arms. The other thing that we definitely see is a little bit of tingling in the forearm and fingers. Now, I know the folks at miraDry have some very, very cool technologies and strategies to reduce that. But people do get it. It's temporary. I've never seen it be permanent. And so basically what we tell patients is you're probably going to get a little bit of numbness and tingling. It doesn't affect your motor skills, but it goes away. And as long as our patients are prepared for it, they're okay with it. And those are the 2 things that we see. Sometimes you can see a little bit of a hickey in the underarm from the suction and a little bit of bruising from both the suction and the injection, but that's basically it.
Great. Okay, here's a question. Would you still do laser lipo procedures on any selected cases instead of miraDry, or is this procedure now a thing of the past?
Well, this is where my conflict of interest becomes a little bit more apparent because, I've spent so much time doing the miraDry procedure that, to me, it's my preferred route. There are a lot of people, and I've spent some time talking with some of the laser companies, and I do laser lipolysis for fat reduction and skin tightening. So I've done a lot of these procedures. Because of the density of the sweat glands, and again, keep in mind I'm saying this from a slightly biased position, but because of the density of the sweat glands in the axilla, you can imagine that with a 1 millimeter laser fiber, it would be a challenge to get all of those sweat glands in one treatment. And what we've learned from miraDry is if you have any skip areas, the patients still sweat and they're unhappy. And so although I think you could probably reduce sweating with laser lipolysis, the density of the sweat glands in the axilla I think is going to make it a real challenge to fully get all those sweat glands to go. And it may be something that's doable in time, and obviously it's invasive. So my bias would be that, non-invasive treatment would be a little bit easier for our patients, and I think having a slightly higher efficacy. But again, time will tell how the laser lipolysis folks do going forward.
All right, our next question. Does this procedure eliminate hair and odor, and are there any other indications?
Yeah, that's a great one. So it definitely gets rid of odor. I've learned a lesson about different cultures. It's very popular in Japan for the odor reduction component specifically. So there's absolutely no question that miraDry, as opposed to Botox and the other toxins, that miraDry specifically will help the odor, whereas the other ways of treating axillary hyperhidrosis cannot, aside from laser, but let's put that aside for a second. So Botox gets the wetness of sweat, usually not the odor. miraDry does, but the apocrine and the eccrine glands are right near each other. And so I think it's a great way to get rid of odor because it's predictable. In terms of hair, that was a sort of one of those serendipitous observations that hair went away. Now, we've done some studies asking men, do you care? And in 2012, guys don't care if they have underarm hair. So interestingly, I think it becomes a reasonable option, both in terms of treating their sweat, because they don't care if their hair goes away. But as a therapeutic option going forward, there may be a way to either use this as designed for hair removal or with some subtle or maybe even not so subtle changes in the technology to target hair. So it's promising, and I think it's potentially a reality.
Okay, here's a question asking if patients will see long-term damage, i.e. cell phone.
Oh, cell phone damage. I get asked that question all the time from patients. There are two ways to answer it. I'll give you the scientific answer, and then I'll give you the way that I tell my patients. The scientific answer is that, first of all, there is now some data to whether cell phones specifically cause any form of permanent damage or increased cancer risk. So there's a question mark there anyway. But second of all, that's from long-term use, right? So if you're on your phone an hour, 2 hours a day, even a half an hour a day, for years, if it does even have a risk, it's a cumulative risk based on hours and hours and hours and hours of exposure. This is 2 treatments. The total microwave on time is about 30 minutes per treatment. So you've got 2 treatments. You've got at most an hour. Let's say you even go crazy and do a third treatment. That's 90 minutes of microwave on time, and that's not even next to your brain. That's, at least a foot away from your brain. So first of all, the time duration is too short to cause these side effects that may be attributed to cell phones. What I tell patients is, the cure that everybody said for the risk of cell phone injury was to not hold your phone to your ear, but to use earphones or an earbud, which is what I am doing right now. My cell phone's on my desk right next to me, and I'm using earbuds. And everybody says, oh, great. If we use earbuds, we don't have to worry about cell phones causing brain cancer. Well, your underarm is about as far away from your brain as your cell phone is when you're holding it and talking with earbuds. And so the distance from the brain as well as the time duration are the 2 variables that I think and they made the FDA comfortable as well. So I think of it as a non-issue, and that cell phone discussion about holding it with earbuds is what makes at least my patients comfortable as well.
Okay, great. Let's take another one here. Can other energy systems do the same thing as the miraDry system?
Well, it's really interesting. 2 weeks ago, we were at the ASLMS meeting, the American Society for Laser Medicine and Surgery, and I was hoping that this would happen, and it did. All of a sudden, sweating is on the podium. 2 years ago, nobody really cared at all about sweat. Now there was a whole panel discussion and presentations devoted to sweating. And I think Miramar may have been the one that kick-started it, but there's a lot of other companies out there trying to do it. So I know that Ulthera is looking at ultrasound, and we've already talked about the laser lipolysis. The thing that I always keep in mind is the density of the sweat gland. The only technology that I'm aware of that gives confluent heating to destroy the sweat glands, and we've learned even from Miramar over time as we developed the technology, that confluent antennas, the delivery of microwave energy, is the key. Ulthera delivers very small injury zones, similar to the way they do on the face. So intentionally, Ulthera is designed to have skip areas. So, there's a limitation there just from the physics. And we've talked about the laser. So, look, I'd love to see everybody be successful. I'd love to see everybody be able to treat sweat because that's what's ultimately going to help our patients. But those other technologies have things about them in terms of the way their physics work. It just made me wonder how predictable and how effective they're going to be over time. But again, we'll just have to watch and see.
Okay, we're getting close to our time, so I'll just pick one more question here. We've had several folks ask in a roundabout way, how long does a sweat reduction last following treatment? What can they expect?
Long-lasting, if not permanent sweat reduction. And this is data-driven. We have patients out to 18 months who have stopped sweating. And I should make sure I'm clear. When people are improved with miraDry, they go down to become an HDSS 1 or 2. They sweat like normal people, but they're not bone dry. And so at 18 months, our patients who we've treated across the country and in Canada are sweating like normal people, and their sweating is stable. If you look at their data, it is rock solid in the mid-90% efficacy without any drop-off with time. And so we have some patients who are now out to 2 years, and I think the answer is it's probably permanent. We have data that proves it's at least 18 months to 2 years, and since humans can't grow new sweat glands, it's hard to imagine how at 2 years people are going to automatically start sweating. So the logic says it's permanent, but the data says 18 months to 2 years.
Okay, well, I think that's probably about it. We're pretty much running out of time here, so just want to say thank you, Dr. Kaminer, for your time and let you close us out.
Well, thanks, Chris. I really appreciate it. Once again, thank you, everybody. I hope you found it helpful. I really enjoyed getting to spend the time with you, although I couldn't say anybody, but I enjoyed it. Hopefully you did as well.
This concludes today's presentation titled Don't Sweat, Utilizing Microwave Energy as a Platform to Treat Excessive Sweat.